good afternoon, everyone. So thank you very much for coming to this session, live case and lecture 7, new TAVR with Navitor valve. So I'm going to chair this session, Dr. Kentaro Hayashida from Tokyo, Japan. And I would also like to introduce distinguished panelists, Dr. Bai, Dr. Hom, Dr. Ho, Dr. Kim, Dr. Lee, and Dr. Zhang. And today we're going to have the live demonstration from the Kokura Memorial Hospital, Japan. And I would like to introduce the center. So could you connect to the Kokura Memorial Hospital? Hello, Shinichi, can you hear me?
Hi, Kentaro. Can you hear me? Okay.
Yeah, perfect. We can see you,
thank
we
you
can
very
hear
much.
you. Yep.
Yeah, thank you very much for inviting such a great opportunity for a TAVR live demonstration for AV valves 2023. So I want to introduce our teams. Second operator is Dr. Hayashi. Third operator, Kenichi Ishizu. And he is operator of intracardiac echo. And he is Dr. Fukushima, Dr. Miyahara, Dr. Nakano, and Dr. Suenaga, Dr. Otani. Not Angels Otani, okay? And he's Miyawaki and Dr. Yamamoto. So, and the nurse staff are Takayo, Miyu, and Shoko. And the anesthesiologist is Dr. Kakumoto. Kakumoto is just back to the II, okay? And the radiologist is Takaharu, and the critical engineer is Mr. Taninobu, okay? So today, I want to introduce our case. Okay, Kentaro?
Okay, perfect. So could you please continue the introduction of your case?
Okay. So the slide is on the panel now. Can you see?
Yeah, we can see the slides.
Okay. Okay, you can see?
Yeah, we can see the slides.
Okay, so this case is a Navitor case. So the patient is 87 years old woman referred to our hospital due to dyspnea manifold and frequent syncope. So TTE showed severe aortic stenosis and anatomy was suitable for TAVR with CT analysis. And she was already implanted the pacemaker, and the implantable cardio monitor was inserted. But yesterday we removed it because of the difficult to see the angle. Next slide, please. And no diabetes and no hypertension, and the height is 151 and 51 kilograms, BSA 1.46. ST score is intermediate, score is 4.824. And the clinical frailty scale is 4, vulnerable. And now she suffers from the heart failure with NiHA+2. Next slide, please. So the chest X-ray shows the pacemaker and implantable cardio monitors, but already cardio monitor was removed. And this patient is a complete, not completed every block, and intermittent every block. So in usual, her ECG shows the sinus rhythm. Next slide, please. And this is still images. Ejection fraction good, and the LVDD is DS was 38/24. The mean pressure gradient was 43, and the peak gradient is peak velocity is 4.4. Aortic valve area is 0.76. Mild area and mild MR. Next slide, please. And coronary angiogram shows the no significant coronary stenosis. And the RCA austere is ectopy from the left coronary cusp origin and very high positions. However, the LCA originated very low position, 9.9. So a low coronary height. Next slide, please. And the tricuspid valves and the mild calcification and the small, very small annulus, area 274.5, and the perimeter is 61.1. It's the junction also small, around 22 and 20. And the valve width is 26.9 to 24.6. Next slide, please. And as you can see, the coronary height, right, is a very high positions, but the left side is very small, very low. And the membranous septum is 4.1, but after that, we will show the IC images. The length of the membranous septum is a little bit fluctuate. So today, from the IC analysis, the membranous septum length is around 3.3. 3.3, a very, very short membranous septum. Next slide, please. And the ankle is okay, and the lower extremity is good for TF. Next slide, please. So we decided to use the Navitor 23 millimeters valve because, according to the perimeter analysis. Next slide, please. And the Navitor valve is a self-expanding and the intra-annular leaflets. So one of the great point is a large cell design, so easy to coronary access. And the outer nerve shield cuff also prevents the massive or trivial, moderate to severe aortic regurgitation. So most of the cases, in this institutions, the regurgitation grade is usually trivial to mild. Okay, next slide, please. And the flex nerve system is a very steerable and have a trackability. So it is very easy to deploy the valve to the aortic annulus in spite of the shallow aortic arch. So maybe so also other companies' system is also improving now, but the Navitor system is extremely great. Okay, next slide, please. So today, in our strategy, so under conscious positions, from right femoral or using the 14th French dry shield and exchange to the sheathless implantation. And the pacemaker and pigtail is inserted from the groin. Okay, I want to go back to Kentaro, okay?
Okay, thank you very much, Shinichi, for your beautiful presentation always. In the case of 87 years old female and previously implanted pacemaker, and that's great. And peak flow velocity 4.4. She also has a really small aortic annulus with a 274 millimeter square and perimeter of 61. And the coronary height of the left coronary is the 9 and relatively small. And can we discuss several minutes for the case, or would you like to proceed to the procedure immediately? So, Shinichi, maybe...
okay. So I already inserted the dry shield and pigtail into the left ventricle. So I exchanged the pigtail to the safari wire.
Okay.
And during procedure, please discuss.
Okay, so maybe you can start procedure, and we're going to discuss the case among the panelists. Maybe I would like to ask the Dr. Hyo-Soo Kim. In this case, a really small aortic annulus. So do you have this kind of case in Korea?
Yeah, we have many cases like this small body-sized female patients having small annulus. There's usually in Japan, you treat these patients with SAPIEN 20 or 23.
Yes, we used to do.
But I think the intraannular TAVI device does not provide a wide effective orifice area. Thus, in my personal strategy for this small body-sized female, I always use supraannular design valve.
Okay. So maybe
Sorry,
today.
Dr. Kentaro.
Go ahead. Go ahead.
I forget to state, declare my COI. Sorry.
Okay.
My name is Shirai, and then proctor for the Navitor. Okay, thank you very much.
And you're the top operator in our country, right?
Not the top operator.
But my question is, SAPIEN and Navitor has the same structure design, intraannular device,
Yes.
while one is balloon expanded, the other is self-expandable. Thus, I want to know the effective orifice area between SAPIEN and Navitor. I think Navitor may be less than SAPIEN. What is the truth?
Really? So in our institution, the patient with a Navitor valve, and so the Navitor is a cylinder-like system. So the post pressure gradient and maximum velocity is lower than the balloon expandable valves in our institutions.
So, Professor Kim, surprisingly, Navitor provides as good as hemodynamic as the VALVES. So we will see.
Wider than SAPIEN.
Yeah, better than SAPIEN, I think.
Yeah.
Okay, so Shinichi, could you please explain the
Yes.
what you have done and
Yes.
what you're gonna do next step?
Yeah, thank you very much. One of the weak points of the Navitor valve is radial force is stronger than the other self-expanding valves. So most of the case, the pre-dilatation is mandatory. So then we usually use the retrograde in-way balloon. So it doesn't need the rapid pacing. Okay, じゃあ、まだ。
Okay, go ahead.
OK。And 80。100。はい、じゃあ行きます。ペーシオン。はい。OK。はい。あ、多いよ。いいよ、OK。OK, thank you.
Perfect. So, do you use pacing on regular basis for in-way balloon?
Yeah, not the rapid pacing, the control pacing only.
Okay.
Okay.
Maybe Dr. Ishizu, could you please comment on the ICE-guided TAVR procedure?
Okay, thank you, Dr. Hayashida. In our institution, we usually Akunabi ice catheter inserted from the right carotid vein, and the tip of the catheter located at the tricuspid annular level. And could you see the ice images?
Yes, we can see that.
Okay. The green pointer indicate the tricuspid valve and the aortic valve and the LV wire in a good position along with the septal. And this most thinner part is membranous septum. And in case the bottom of the membranous septum is somewhat ambiguous, but that this is bottom, and the bottom of the membranous septum is risky zone.
もうこれ大きすぎかな。もうちょい。
For
Okay, Dr. Ishizu, perfect. So
Yeah.
you always monitor membranous septum by
yeah,
ICE. And Navitor is too good to cross the aortic valve and
Yes.
negotiate idiopathic access. And so Shinichi, could you please explain step by step your
Yes.
technique
So
to deploy Navitor?
we now insert the valve into the left ventricle, cross the valve, aortic valves. So the Navitor is very soft and have a good trackability. So in usual, and it's the same implantation of the Evolute. Usually the guiding catheter usually runs through the outer curvature side. So And we usually first and the depth side and then, okay, and open. And another good point for this technique is preventing the NUE, non-uniform
Expansion.
expand. Okay, the pace 100 and 100 で on. So in some doctors, and there no need a pacemaker, but in order to implant the optimal position, we usually use the temporary pacemaker. Test. Okay.
Hemodynamic is quite stable.
Yeah. And this is at first we implant this valve from the cusp forward view.
Okay.
It is the same, but it is extremely good trackability. So most of the cases, the valve projection is parallax. So, and we go to the perpendicular view. So we go to the perpendicular view. Okay.
Okay.
Okay. And go to this perfect.
You opened up the distal part inside of the left ventricle to avoid non-uniform expansion.
Yes.
And then you deploy
so how do you think there is no NUE now?
Yeah, it looks good.
Good. Okay. So go to the LAO. So usually we implant this valve from the view. I think this is very shallow.
Okay. So Shinichi, could you tell us what is the target depth with Navitor valve?
Yeah, 3 millimeters depth. Okay.
3 millimeter.
Yeah, extremely shallow. So please show the please show the images. So it is bad because the catheter through a little bit greater curvature. So best point is the catheter runs the center of the aorta, and the annular plane is usually the dot, just below, under the dot, just below the dot. So we try to recapture now.
Okay.
In the eyes, we can see the bottom of the THP is does not attach the bottom of the membranous septum, and but in Navitor valve, this position is so shallow.
Okay. Could you please point the lower end of the Navitor valve on eyes image, if possible?
Here.
If it's difficult, it's okay.
じゃあ、リキャプチャーしよう。いや、フル。
ちょっと無理だったらいいっすよ。ごめんなさい。
すみません。
そのまま行きましょう。はい。
じゃあ、フルリキャプチャーします。
Okay.
We plan to full recaptures.
Okay. Could you show blood pressure?
Okay. Oh. No? Okay. Now it is quite stable. 112 over 50. Okay.
Okay.
いいよ。
With the recapture.
And could you switch the image from eyes to blood pressure?
Okay. もう一回。So extremely shallow. Okay. もうちょっと
ワイヤー入れますよ。
いいよ。
はい、どうぞ。
アイス画像を血圧に変えてもらえますか? Okay, perfect.
テスト。
これって入れ替えれるのかな。
いや、多分向こうの話。
でも向こうが。
It's perfect now. Thanks.
Okay. いいよ。
Okay.
いいよ。
This is perpendicular view, right?
No, LAO view.
Or LAO, okay.
Three cusp view? No?
No, LAO view, not cusp overlap.
Three cusp view.
Three cusp.
No,
Okay.
from three cusps view to the LAO. ちょっとこれ撮影するわ。
LAO view, right?
Okay. LVOT side is very narrow, so I'm very afraid for the pop-up of the valve.
Facing?
Pacing, please.
But please
100.
take your time. We have
Okay.
plenty of time.
OK。テスト。OK 行こう。はい、開いて。
If you finish too fast, it's gonna be a problem. So take your time.
OK。じゃあ、いいよ。
ごめんなさい。
そうそう。いやいや、逆に回してるのに。He rotated ね。
ボールとよく考えたら逆や。
He's
OK。
he's familiar with the voltage system, so OK。
ちょっと深いですから、これ。
これで OK。
OK。
テスト。
ペーシングアップする？
ペーシング100。
もうちょっと上げますか。
120。
Nice position.
OK。
It's very similar to the Evolut system.
Yes, but it
Yeah,
tends
very similar.
to lay down.
Just push, pacing off.
It's much
pacing off.
softer.
Software.
Yep, and lay down tends to lay down.
OK じゃあ AOG。OK, I think it is better.
Looks
Yep.
better.
Much better.
OK. And in usual, we wait for 5 minutes.
Okay.
And during 5 minutes, we discuss about everything.
Okay.
Everything, such as the coronary height or recent pressure, recent, sorry.
Okay.
Maybe I can ask one question.
Yes,
Yeah.
go ahead.
This is the same approach that we do. We start in CAS overlap, and we see a parallax,
Yep.
Yeah.
and then we remove parallax, go to LAO, and then it's mostly caudal.
Yep.
And then we see it's too high, and then reposition.
Yep.
But where's the use of using the CAS overlap then?
So you're asking.
Why not start with LA or caudal, right?
Okay.
Yeah.
Because if you go back to CAS overlap, then you see it's too deep.
Yep. That's true.
It's like a I make the same mistake. So the question is,
Yeah.
So
maybe it's better to look for the double S curve.
yes, that's right.
Shish, do you have any comment on that? Or
Yeah, so double S curve. So from the point of double S curve, the cusp overlap depth is ideal positions, but this valve usually cannot catch the LCC. So at first, then we start the cusp, implant the cusp overlap view, but sometimes parallax and the sometimes the valve left coronary cusp is not catched. So we got to the LAO, and finally, this valve is usually spontaneously pop up. So
I think in this case, usually it depends on the anatomy of the patients, because if you rightly keep the cusp overlap view, in usual case the valve implantation is coaxial with the annulus plane, annulus axis. But in your first deployment, even though that is annulus plane is well preserved, but valve is obliquely implanted. Because I think in this in this specific patients, the axis of the valve and aorta is kind of different. That's the reason why cusp overlap view is not helpful for this case.
That's right. So it is very difficult to correct answer to answer the true because from our experience, so we have several complications such as the pop-up. So we up to reach to this position. So sorry, I cannot answer.
It's okay,
So do you have any answers Dr. Kentaro.
Yep. So actually, both Dr. Kim pointed a really important point, and we're using both RAO cusp overlap view as well as the perpendicular view, LAO view. And usually cusp overlap view looks deeper. The valve seems to be deeper. And on the other hand, if we go to the LAO, it seems to be a little bit shallower. And I personally start from 5 millimeter at the cusp overlap view, and then so I move to the LAO view, and we usually looks like 2-3 millimeter. That is my practice. So in this case, the Shinichi nicely pointed out the valve seems to be a little bit shallow in LAO view, and he has a really nice technique to reposition the Navitor valve at exactly the correct position, 3 to 5 millimeter. And now the valve position quite excellent, and PBL is the very minimal. So he demonstrated a really nice deployment method and reposition method for Navitor valve. So,
Okay, we final check.
and this
So remove the pigtail,
okay.
and then we go to the release position. So in release, in usual, other proctor usually runs fastly, but in Kentaro and I are in our institution, so slow deployment. And the most important thing is never push, such as the Evolute series. Okay.
Yep.
So we gonna
She
release.
pointed out a really important point. Don't push the device. Otherwise, it cannot be detached.
Yeah. And release point is already, okay, stop. And spontaneously up. 深さは十分、石井先生。はい。Suddenly, the valve was released abruptly.
Yeah, usually it takes a really long time.
Yes.
Yep. After
order to prevent-
rotating, yep.
Abrupt opening.
So we need to take time.
I'm sorry. Maybe the last 10 minutes.
Why did you remove the safari
Okay.
wire?
Remove the safari wire, yeah.
Why?
In order to make a coaxiality, because if we have inserting a safari, it is very difficult to make a coaxiality, spontaneous coaxiality. It is the same reason for the Evolute series.
Yep. I also removed the safari wire. You still have one tab.
Yes. One tab is so sometimes very difficult to あれを rotate.
It's important to know that Navitor has 3 tabs and
OK, free.
good.
ちょっと待ってよ。じゃあこれ質合わせようか。もうちょい。LO じゃない。じゃああれをか。あれをだ。OK。
じゃあここで
OK。
2 lectures.
What do you think is the deadline for transmission? 40?
OK
I showed no migration of THP with trace PBL.
Okay, trace PBL, perfect.
Yes.
And the position looks great.
Yes, and this patient is a low coronary height, LCC.
Yep.
So, and fortunately, this patient already implanted a pacemaker.
Yep.
Yes.
Very good patient selection.
Thank you very much. in live case demonstration, one of the most important thing is a patient selection,
Yes,
I think.
totally agree with you.
Already, she has a permanent pacemaker and coronal height is a little bit low. Then
Yeah.
you should target a little bit deeper implantation.
Yeah.
That's
Yes.
why he put the
But
this position.
it is very shallow. What average depth?
4-5 millimeter, maybe.
Average. Okay.
I think really good position.
So in usual, we implanted that below 3 millimeters.
Okay.
So, yeah. And the final hemodynamics.
Yep. This is the most important part of this lab demonstration, showing the hemodynamics of Navitor in extremely small aortic annulus.
0。
0点
In case valvulate, in the final release, we have to always advance the system. But Navitor, no?
No, and after detachment of all the tab, we can push or pull whatever we want. But if we push the device during deployment, it may cause the difficulty of the detachment. So maybe Shinichi, could you please explain the hemodynamics?
Yes, so as you can see, there's no residual pressure gradient, and maybe
グラディエント何本
AR index
Air index looks
is also
wonderful.
high, I think. Maybe almost no paravalvular leakage.
Yeah. Over 30.
No pressure gradient.
2
Okay.
Perfect hemodynamics.
Yeah.
It was really surprising to me that the intraannular self-expanding device has really nice hemodynamics, but it is.
Yeah, maybe I can comment on that.
Yes, please.
Intra-annular, but you have to be aware that the leaflets are a little bit higher.
Okay.
The leaflet position is at 7 millimeter, so it's not strictly intra-annular, and the leaflet coaptation opening is complete in comparison to Sapien. So that's why you have better EOA than with Sapien.
And it also doesn't have the significant waste. Great.
Okay.
Dr. Kentaro,
Enough depth.
regarding the commercial alignment, is there any tip for the navigator?
5ミリか。
Okay. And Shinichi, could you please comment on any
Yes.
tips and tricks to achieve commissural alignment
Good point.
with this
Yeah.
Navitor valve?
Yeah, it's very difficult to make a commercial alignment in this valve because it is almost invisible
最後の出しといて
of the commercial post. So
That's a kind
I
of
want to know.
one limitation. Yeah. The Vascular developed strategy, commissural
Yeah.
alignment for Navitor system. Okay.
yes.
Okay. So Shinichi,
Thank
could you
you.
please explain the final result?
Yes, final angle shows the almost no aortic regurgitation, as you can see, and the coronary is good flow. And in usual, we intended to implant 3 millimeters depth, and this time 5 millimeters depth in this case. So
Perfect depth.
another commentator said so. I really agree with that. This valve is intra-annular, but a little bit supra-annular compared with the balloon expandable valves.
Okay, perfect. And Shinichi and the Kokura team, I really congratulate on the great success and the perfect result with the Navitor valve with this really small reticulous patient. And we're really happy to see your finest technique as well as the really good teamwork. And you're the real top operators and the top team in the world. Thank you so very much for the fantastic
Thank you
live
very much.
demonstration.
Yes, thank you very much for thank you.
Now we are going to have two lectures, 10 minutes each. The first speaker is Dr. Kentaro Hayashida from Keio University School of Medicine, Japan. His title of lecture is Current Status of TAVI in Japan, the OCEAN-TAVI Registry. Dr. Kentaro, please.
Okay, thank you very much, Professor Kim, and ladies and gentlemen. So today we're going to talk about the OCEAN-STD family. And this is my disclosures. Actually, the TAVR was introduced in Japan in 2013, and now we have SAPIEN 3 Auto-Auxilia and Evolute FX, and we also studied the Navitor valve from the last year. And we also have the Matroka G4 and the Watchman Flex. And we are organizing OCEAN-STD family, including TAVR procedure as well as mitral and appendage closure. And we also have the 28 centers on board, including 280 members so far. And till the end of the last year, we accumulated the case number of the 14,000 TAVR and 3,000 mitral clip and 1,400 appendage closure. And nowadays, the case number is increasing day by day. And we already published some paper, and 100 papers so far, and more than 50 projects are still ongoing. And I would like to introduce some papers from our registry. And this paper demonstrates the impact of clinical frailty scale on the late outcome after TAVR procedure, and led by Dr. Yamamoto from the Toyohashi Heart Center. And we also published the data about the prosthesis-patient mismatch. And interestingly, severe prosthesis mismatch is noted in only 0.7% in our registry, and that is much lower than that of the American registry, like the 9%, presumably due to the less incidence of obese patients in our cohort. And we also published the difference between DOAC and warfarin in terms of the clinical outcome after TAVR procedure. And DOAC did better in our registry, and that is led by Dr. Watanabe from Tokyo University Hospital. And we are very much pleased and honored to be the part of the TAVI global trial led by Dr. Nicola van Meegen. And our OCEAN group was chosen as the part of the Japanese cohort. And this study demonstrates the non-inferiority of edoxaban to warfarin. And we also compare the SAPT, clopidogrel, and aspirin. And according to our data, clopidogrel did better as an aspirin. And we also checked the no anti-thrombotic or no antiplatelet regimen after TAVI procedure. And no antiplatelet therapy was associated with the lower incidence of bleeding, but it didn't increase the NACE. So therefore, we are now conducting the randomized control trial to compare aspirin alone and no antiplatelet therapy. And this is multi-center randomized control trial, including 20 centers so far. And we also published the impact of pre-procedure pulmonary hypertension on outcomes after TAVR. If the patient still have the PH even after procedure, they have worse outcome. And we started from the 4 centers and the 25 centers. Now we are 28 centers. And they are the key member of the registry. And we also demonstrated our initial data on the TAVI for dialysis patient. And interestingly, the in-hospital mortality is quite high as to 5%. The reason for the cardiovascular death was the non-cardiovascular death was infection and non-obstructive intestinal ischemia that is presented in the Japanese Circulation Society this year. And we also demonstrated the early clinical outcome of TAV inside procedure. And Carpenter-Edwards Paramount was most frequently used by prosthesis, and our patient had really a small bioprosthesis. And TF approach was predominantly used in this cohort. And all-cause mortality was 1.5%, and is very acceptable data. And incidence of severe prosthesis patient mismatch was quite low, especially with the self-expanding device. And now we're using the SAPIEN 3 Auto-Resilier and Ablet FX Navitor valves. And MitraClip G4 is also used in a registry. And this data was presented by my friend Dr. Shunsuke Kubo, and acute procedure success was achieved in 94%. And we also had the improvement of the prognosis as well. And even moderate moderate MR might impact the prognosis after MitraClip. So we need to be careful that not to leave the any moderate MR after procedure. And the 30-day outcome was published in JACC Asia by Dr. Mike Saji, and the one-year outcome was published in JAHA by Dr. Shunsuke Kubo, as mentioned. We are also doing the appendage closure, and my friend Masahiko Asami published our initial data in JACC Asia last year. And TriClip clinical trial was conducted in our country, and we have done several cases last year, and now we're waiting for approval. And Evoke device is also introduced as the part of the clinical trial. And I am very pleased and honored to perform the first case of the TTVI in Japan this year. And this year, we have the more than 1,100 active participants for our PCR Tokyo BAPS, and we're going to have the same meeting in the February from 16th to 18th next year. So we're most welcome to come over to Tokyo and join our meeting. So thank you very much for your attention.
Great achievement. Congratulations, Dr. Kentaro Hayashida. The second lecture is Dr. Karl Poon from St. Andrew's War Memorial Hospital, Australia. His title of lecture is Valve in Valve, New Era of TAVR, How to Treat. Dr. Poon, please.
Thanks, Professor Kim, and great work from Kentaro, obviously. So I think the title was TAVI, How to Treat. It's a question, but I don't have answers. But I just want to focus on one of the cases that we've done recently. So this chap was only 68 in 2017 when he presented with severe symptomatic aortic stenosis. He's a Jehovah's Witness, and he objected to have redo open heart surgery, having undergone open heart surgery prior with subsequent multi-vessel stenting. These are his medical background. He's quite obese as well, with a BMI of 38. He was recommended in 2017 to actually have a TAVI at that time. The biggest issue was that the left internal memory artery was adherent to the sternum, making him high risk for redo surgery, even though in those days it was technically low risk. When we talk about TAVI in TAVI, it's always important, if possible, to look back at the original CT. So he had a TAVI at our institution, so we had all the data, including the subsequent procedure. Nevertheless, I think we mentioned something about sizing earlier today. In retrospect, he probably should have just had a 26 millimeter S3, but nevertheless, he did have an undersized 29 or underfilled 29 for this anatomy. So the procedure was unremarkable. He had a 29 millimeter valve, an S3 deployed in a usual fashion, I suppose, and he had a satisfactory result with, not surprisingly, no paravalvular leak with this sort of sizing strategy. So he was, in fact, lost to follow-up, and his local cardiologist, and he lives about 2 or 3 hours away from us, eventually caught up with him, and he did have some shortness of breath, and of course the first thing was an angiogram they did, but there was no coronary ischemia to explain his dyspnea. But over the years, his transvalvular gradient and valve area slowly increased. At year 5, finally, the local cardiologist contacted us when he was very concerned that maybe we need to consider redo TAVI or address the valve. His daughter is a nurse and wondered whether immunotherapy contributed to valve failure. I'm not entirely sure. But nevertheless, when we were notified of very high transvalvular gradient, we admitted him, undertook a transesophageal echocardiogram, and confirmed the pathology being restricted leaflets, heavily calcified, possible thrombus. I think the reality is that if it was thrombus, it's been there for too long for anticoagulation, but we tried that anyway. So it was discharged on DOAC and was really planned to return for TAV and TAV. So I think this case hopefully can give an insight in terms of how to deal with TAV and TAV. We need to confirm the diagnosis. Treatment may be different if it was stenotic or regurgitant failure. It's obviously important to exclude other diagnoses and confounders, resting LVOT gradient or original patient prosthesis mismatch, which is probably unlikely in this case, a large valve, and exclude endocarditis. There are some steps to follow. We are still grappling how to deal with these cases, and I'm sure over the next few years we'll keep seeing live cases of TAVI and TAVI because there's a lot to learn. But obtain the original CT, understand the original sizing algorithm, sizing decision, valve decision. Was the valve undersized or oversized because of hostile calcium at the annulus? Look at the original implant. Perhaps if you repeat the CT, you get a lot of the information anyway, but look at the coronary ostia and obviously work out whether the coronaries are protected. Understand the root anatomy. But of course, the critical part, like all things in TAVI, is to look at the CT or undertake a CT to look for the risk plane, the possibility of TAVI, kneel, skirt, coronary obstruction, the risk of sinus sequestration, and also understand the original TAVI device expansion profile. So these are all new terminologies we're learning over the past 12, 18 months. The idea of a neoskirt. When we put a new TAVI in there, we make the original valve like a stent graft, essentially, a tubular structure. So the neoskirt and above the leaflets, the risk plane, whether the coronaries are at risk, the idea of sinus sequestration, not exactly new, that we've already learnt in the days of TAV and SAV, but we now have very long valves and sometimes supraannular leaflets, which will all have implication for TAV and TAV in terms of feasibility. So this was the CT analysis. Now that is returned for possible TAVI and TAVI. The best news, I suppose, for this case, like the live case this morning, the risk plane was not obstructive in terms of coronary perfusion. So his THV was placed lower than the coronary ostia, and that was probably fortuitous, and that may have some bearings in terms of how we do TAVIs now, your very first TAVI in a patient, where to put it. But most critically, and it's a point I try to highlight in balloon expandable, the valve is almost never as expanded as you would want it to be or expect it to be. Now, there's some pathology in the mid-body of the valve, a bit of calcification, but the measurement tells you that the valve was never fully expanded. But we did take the underfilling strategy, so maybe that was to blame. But even then, the valve was never fully expanded. Now, a fully expanded 29 S3 should be 22.5. So as a consequence of the underexpansion, there's also lengthening of the valve. But we were lucky that the coronary ostia were not going to be in the way. So we've made the diagnosis, couldn't really change the trajectory with anticoagulation, and the plan is really for TAVI in TAVI. And we were lucky that the coronary risk, obstruction risk was not there, essentially, unlike perhaps a higher placement or supraannular leaflets. So we didn't know how it would behave in terms of expanding the original valve. Already knowing that it was underexpanded, I thought it was very important to expand the original stent strut. I think this would be, by definition, somewhat complex. Sentinel, we thought was reasonable. Before we did this case, we knew there's been some anecdotal reports of the inability of post-dilatation if you were to do BEV in BEV. So I had some advice to consider true balloon pre-dilatation before the TAVI. Because we weren't sure how to pre-dilate with the true balloon in the tissue valve, we were concerned about torrential regurgitation. So we had contralateral access and traversal of the valve as well for want of a better word, valve fracturing with a true balloon, or really aiming for true expansion. We think there will be multiple embolic risk in this case. We wanted to address the underexpansion, high pressure inflation, so rather than a 29 again, use a 26 and added extra volume and post-dilate. So you can see that there are two wires across the 29S3. One was to aim for full expansion with a true balloon, and then surprisingly perhaps, or thankfully, there was no torrential regurgitation. And then obviously the critical part here is not to deploy the valve without taking the wire out. So took out the wire, took out the true balloon, deployed the valve with the top post aiming at the same level. This was deployed at 9 atmospheres with an overinflated or overvolumed. So we did then, this was TOE guided as well. Subsequently, we did the true balloon inflation, and then we noted further expansion and reducing the coaptation, and there was a huge matter that was caught in the Sentinel. But I'll just make some final points. Even here, with all that pre-dilatation, the expansion was still a struggle. But we had satisfactory gradient reduction. There's probably a lot of tissue in between the stent struts, and maybe it will never expand. But think about the third valve that we sort of talked about before. Is this really going to work? So I might just skip through some of these, but raise more questions than I perhaps answered. Do we need to think about the first valve? I do think that the intra-annular leaflet, that is Navitor, perhaps is more promising as a self-expanding device. What's the optimal redo TAVI device? Do we always need to pre-dilate the whole permutation of self-expander, balloon expandable, etc.? How are we going to deal with a lot of tissue in between the TAVI devices, and where do we place it? All these node 4, 5, 6, and dealing with Evolut, TAVI and TAVI. So there's been some case series, as we all know, focusing on feasibility and survival in TAVI and TAVI. And this is like TAVI 20 years ago. The aim was to get the patient off the table. But there's a lot of cases that are not reported in terms of how to deal with TAVI and TAVI. That's not feasible. Explant is probably not the answer, as we alluded to before earlier today. There are many strategies for leaflet modification that's coming up in trials very soon. So in younger patients, more and more important to think about the first valve. So I might just close there with all these questions to be answered. Thank you.
Thanks for your nice lecture. Yes, just one question for Dr. Poon. We always see the many cases of valve fracture in case of failed small surgical valve. How about failed TAVI valve? Is it possible to do a fracture, or is it safe? Because always we believe TAVI sizing is appropriate for the native annulus size.
Look, that's an excellent question. I don't know whether we have answer to that. I think what we know is that, like I said, the valves are usually not fully expanded, even balloon expandable. It's very important to prepare that valve. I don't know whether the strategy we pursued was really just to fracture. I mean, there's really nothing to fracture other than to expand a stent furthermore, right? I think that strategy has to be considered, because if your original anatomy was such that there was concern about rupture, doing it 10 years on, 5 years on, there's still the risk. This is all about further expansion so that you don't have more or higher and higher reduction of EOA. I'm not sure whether this will fracture anything, but expansion is important. I also did not know how the leaflets will behave. 5-year leaflet may be different to 10 years. And this is why, in general, when I do TAV and SAV, I don't pre-dilate, I post-dilate. But with so much stent and tissue, I don't know the answer to that. This is why it's so important to collaborate and learn and share.
In your case, 26 millimeter SAPIEN valve, what did you do actually for pre-ballooning? Just 26 millimeter balloon?
Yeah, so
with
I did
high
a
pressure?
true balloon, true Kevlar balloon, 26 to pre-dilate. Then I did a 26 S3, as you said, over-volumed it so that I made sure that it will be as expanded as possible. Then I post-dilated with the true balloon again. That's a good point. There's no, I went to nominal. It's not like we're trying to crack it and just went up until the balloon, the pressure dropped.
Okay, thank you very much, all the three speakers and all the panelists. A wonderful session. I conclude this session. Thank you.